It's just like a perfect storm right now. ERs are packed. We don't want hospitals to focus on, I want more patients because I can make more money, I can order more tests, I can admit more people. So if you're volume based, so you're fee for service, that is not really the motivation I think a patient wants. We have to switch to value, getting physicians to understand they're not a great physician only because they make the right diagnosis and come up with the right treatment plan.
Right.
I mean, that's really important. I get that. But they also have to connect to the patient. We can make them much more efficient by optimizing their workflow with AI and automation. Patients spend time waiting in the ER. What can we do with that time? How can we make that time more useful instead of them just, sitting there staring at a TV or wondering why it's taken so long? There's a lot of things that can be done.
Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Subscribe now and stay on the forefront of the digital healthcare revolution.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civitaris, and today I'm thrilled to be joined by Dr. Tom Scalleta, founder and CEO of Auscura and practicing physician of emergency medicine. Dr. Scalleta holds degrees in mathematics and computer science from Loyola University and began his career as a programmer at an actuarial firm. He earned his medical degree from the University of Illinois and completed his residency in emergency medicine at Northwestern. Board certified in both emergency medicine and clinical informatics, Dr. Scalleta is a past president of the American Academy of Emergency Medicine. Welcome, Dr. Scalleta. It's great to have you on the show.
Thanks, Chris. I'm really happy to be here.
So today we're going to be talking about streamlining and automating key workflows in the emergency department like admissions. If you can, please share a little bit more about your background and the work that you're doing at Auscura.
So you mentioned a few of these things, but I practice emergency medicine. I'm at Endeavor Health, which is a 9-hospital system in the Chicago area. My base, I'm pretty much at one comprehensive hospital, is high volume suburban, see over 200 patients a day. It's actually serves the community of Naperville, Illinois. But the first half of my career was as a teaching attending. I worked in county hospitals at San Francisco General and Cook County. So I've done a few different things. And even before med school, I studied math and computer science. I was actually a computer programmer for an actuarial firm. And in 1983, which is pertinent to this, I did graduate work in AI, which
Wow.
It's amazing how far back AI goes. AI actually has its origin in the 1950s, which is amazing. If anybody wants to watch 2001: A Space Odyssey again, you'll kind of see where that came from. But that graduate work I did was like super basic compared to what you can do now. I taught a computer how to play tic-tac-toe. It just knew the rules. It didn't know how to play, and it could, learn to beat you, at least tie you every time. So after residency, I managed a lot of databases for different research projects. 10 years ago, I became board certified in clinical informatics, which is its own specialty. And all this, is, other than saying I'm a nerd, basically, it talks about, my passion is really to apply technology to clinical operations. And that's where Auscura came from. It's a company I founded about 13 years ago now. And the goal there is to apply automation and AI to support value-based care. So we close all sorts of gaps to hopefully improve the patient experience, the patient quality, the experience of the staff working in the emergency department. So that's kind of how I got to Auscura.
Talk to us a little bit about what the current landscape looks like in emergency departments when it comes to hospital admissions.
Sure. I mean, everybody knows what the emergency department's all about, and you probably had an experience with yourself, friends, family in the recent past. If it looks anything like mine, and it looks a lot different than when I started. So I've been there about 20 years. ERs are packed. There's all sorts of reasons for that, but a lot of it is primary care access, which is getting more challenging. Not enough primary care docs out there. We're also not seeing any entities want to build new hospitals. So they're not opening existing hospitals, they're not adding beds. Patients are getting older. which I know from firsthand experience, it's just like a perfect storm right now. So if you think it's bad, and I've seen this again, it is bad, it's going to get a lot worse, I think.
Absolutely. So I know that I've heard you talk about this, for some time. And I know that, ER physicians basically serve as a decision point for hospital admissions. And to me, that's so core to kind of what you do in the conversation for today. So I'm hoping you can talk to us a little bit about that and take us through that. Why is it so critical to both patient care and to a hospital's financial health, as you sort of described the background to us? Why is that inflection point of the ER physician, the ED physician, so important?
Let me start by talking about like a big symptom that's going on as a result of some of the stuff we just talked about with cuts. And that is boarding of inpatients in the emergency department. So, people wonder why it's taking so long. Why I can't get a bed in the clinical area to see the doctor and that sort of thing. And part of that's because those beds are blocked with inpatients because they can't get a hospital bed. And that really, if you think about it, is the waiting room of the inpatient team, are the patients in the ED waiting for an inpatient bed, and they're stretched thin. So it's a big problem. And I think it's a more of a post-COVID problem. COVID, at least for the emergency department, a lot of nurses were less interested in going to our field. So we have the natural attrition through retirement, less people wanting to come in, backed up with boarders. Patients are not happy. Families are unhappy. Sometimes they're furious, and that creates burnout for staff because they're, the front line of all that. So the boarders, basically represent hospital occupancy that is too high. So when you have very few beds available, it's hard to move, say, an ICU patient to the floor in order to get another patient in the ICU. So those really sick patients are in the emergency department and can block half the beds and occupy a ton of staff time because they're the critical ones. So that's kind of the grim picture I'm painting for what's going on in emergency medicine. However, from my perspective, I love applying technology. So, okay, take a tough problem and let's figure out how we can maybe improve it with some technology. And there's a lot more. So we, started talking about admissions, a comprehensive emergency department. So, your typical emergency department receives ambulances and that sort of thing. If you just look at the adults, about 30% of them are admitted. Half of those are Medicare because older patients tend to be admitted more often. What's interesting is even though there's an average of 30%, there's always a range of 20 to 40%. It doesn't matter what ER you look at. It's always about the same. So you kind of wonder, why are some people 40%? And what can we do about that? So that's kind of the opportunity, I think, that I've been focusing on. So to start, why are some people higher? It's not like they have a lower mortality rate. The quality is the same. The explanation, I think, lies in an individual's tolerance for uncertainty. It's like a personality trait. Some people are just nervous in every part of their life. And it's kind of funny that an emergency physician can struggle with uncertainty because like everything's uncertain in our field, but that's where it comes from. So to me, if we can kind of focus on that high admitter and figure out what do they need to shift maybe to the average admission rate, that is going to cause a huge opportunity for opening up beds. So, your boarders will be much less. When we talk about reimbursement for hospitals, sometimes those marginal admissions, the ones that one guy would have sent home, another person admits, those are often what's called observation status. So it's not really a full admission, and the insurance companies pay less, Medicare pays a lot less, and the other is that patients have to pay oftentimes a lot more. So they're like totally not happy about that when they find out retrospectively. So, avoiding admissions, trying to bring down the over admitters is like the opportunity, I think, for healthcare in general.
That's really interesting. And I mean, so you've laid, as you say, it's a grim picture, but there are opportunities here. So we have, government funding that's tightening. We have the baby boomer population that's requiring more care. We have fewer professionals like yourself. And I think your wife too, if I remember correctly. Your wife was an ER nurse, if I'm not mistaken.
Yep. So that's right.
We have less people, kind of in the field. Are there other factors that are influencing why it's so important to get the admissions decisions right now? Like, I have to imagine that there are patient care implications and other sort of facets of this that extend beyond what we've laid out, even just so far today in the conversation.
Well, I mean, you think about where inpatients come from. 70% of them come from the emergency department. They're not elective admissions.
Right.
So this is where all your admissions are coming from. The decision to admit a patient in the emergency department is really an independent decision by an emergency physician. So, you're making a decision maybe 6 times a shift to put somebody in the hospital. My goal is, let's try to move that down to 5 patients a shift. If you're a 40% admitter, can we get you down to the average? And when we do that, we're going to shift the entire average over. I mean, we're going to bring the entire average down. I think the opportunity is, say, to go from a 30% average adult admission rate to 25%. And while that, when you first hear it, it's like, oh, that's not that much. It's huge. It's a 17% reduction of admission. So you're increasing hospital beds tremendously. So I think of the emergency physician as sort of the admission lever, the one that makes the decision, and it's an expensive decision. So if you think about, you put somebody in the hospital and maybe they didn't need to be, you're spending nurse time, hospitalist time, transport, dietary, housekeeping, all sorts of stuff that you could have avoided by just sending them home. So that's kind of where the opportunity lies, and that's kind of what I've been focused on.
Absolutely. So let's talk about that opportunity. And obviously, as a technologist, sort of by training, and an emergency room physician by training, I have to imagine these worlds colliding. And technology, I assume, is going to play a huge role in terms of automating and improving decision-making around emergency department physicians. While at the same time, I'm sure the goal is to maintain quality. So if you can, give us some context around the role of technology in terms of those two objectives, in terms of improving workflow, improving decision-making, and then also how we maintain quality at the same time.
Yeah. So a lot, what we talked about is capacity management. We're trying to slow down the fire hose and do that safely. We're trying to optimize those decisions, and there's a lot of things that can be done. So for instance, and this is huge, emergency department case managers. Okay, these are pretty common now. We have them 24/7 in our ER. We're starting to see some overlap because they're so valuable. Most of these case managers are nurses with many years of ED experience. They're not, brand new. They know how EDs work, and they know which patients need to be admitted. They know what physicians tend to over-admit, so they might spend a little more time trying to make them comfortable with an outpatient plan. So we need more ED case managers.
Right.
I mean, I'm almost going to go so far as to say that it's fiscal malpractice for a hospital CFO to deny the decision to hire into a position just for the reason of like, oh, we can't hire more staff. The ROI for an ED case manager is like 8x.
Wow.
So, let's say they cost $150,000 with salary, benefits, whatever, just to round that up. An 8x ROI is saving $1 million with each case manager or so. So that's one thing. And then when we have more ED case managers, we can make them much more efficient by optimizing their workflow with AI and automation. So what we can do is we can look at, say, patients that overuse the ED. These are patients that there's all sorts of reasons to overuse the ED. I mean, some people are medically fragile. They don't get a choice. They could be managed a little bit more tightly, especially if they have a good primary care relationship. Others don't have opportunities to just call up a primary care and get seen the next day. So they come to the ED. Others have, issues with substance abuse. That's a little more challenging. But again, we can try to manage them as long as we have a team. So the case manager can focus on these patients. Our technology identifies them. We look at which ones have the most opportunity to manage. We will automate the way that they can create a care plan and then assemble a care network. So here, a primary care doc, a psych social worker, whoever is involved in this patient's care, and sometimes it depends on the problem. So maybe a cardiologist if it's related to CHF and that sort of thing. So our technology can make it easy for a case manager to design a personalized care plan, to assemble the care network, to basically it's turned on. And now every time this patient comes in, there's an alert that goes out, and we can tighten the plan for that patient. And we've proven this. We've actually published this at IHI and showed that 8x ROI.
Wow.
So it definitely can happen. You pretty much just have to do it.
I'm curious about kind of where your platform begins and ends, specifically around the data inputs. So is this a situation where the data exists in some other external system, the EHR or otherwise? Or is this such a case where you need to build the data sets around those high use, patients around the ED? And so where does Auscura kind of come in, and where does it integrate with what might already be available to the healthcare ecosystem?
Yeah, so we're sort of the bridge. We are going to take data from the EHR. We're going to add to that. So some things are not in the EHR.
Right.
For instance, the personalized care plan, it doesn't just happen. That's actually hard work for the ED case manager to do. They have to dig in, figure out what the best plan is going to be. They're going to have to call individuals and make sure they're on board with being part of that care team. We will grab the data from the EMR. We will add data fields to it. We'll create, workflow opportunities to make things go a lot faster. So, yeah, I think it's a combination of existing data, adding data, and then doing really important things with it that sometimes definitely takes automation and sometimes takes AI.
I also think it's really fascinating that you have this kind of marriage between a human and the machine, where you talk about the importance of an ED case manager, but being able to optimize that resource through technology. And I have to imagine, I guess, first that obviously the pool of talent for those ED case managers were struggling as an industry finding qualified people to take those positions, just like we are kind of everywhere else in healthcare from a staffing perspective. And I guess, is it even possible to think that the industry as a whole would be able to provide the level of communication and so on with a patient without the technological component to that equation? Can humans do it alone, or are we really at a point where, to make this feasible, the technology needs to play a role in this?
Yeah, I mean, you can do things manually, right? But I could probably take that amount of work effort and bring it down to 10%, and sometimes even get more out of that.
Yeah.
So, example, we talked a little bit about this model where we will come up with an optimal care plan and assemble the care network and communicate. That actually came from a program, I think this might have been 10 years ago, that was published in Washington State, where an emergency physician worked with a case manager and probably had literally a Rolodex. I mean, the old style, every patient's on a card, wrote what needed to happen, and did it that way. And it was effective, not as great of an ROI because you're not going to get as much work done with individuals doing this. But we basically automated that workflow, and that is kind of where our technology came in. So we'll steal great ideas that are very manual, and we'll modify them and make it really simple. One more example of that would be where Auscura came from in the first place. The origin of it was important to do patient callbacks. We used to have nurses that would their whole day would be calling up patients that were seen in the ER yesterday to make sure they're doing okay. They don't have any needs, like their prescription was too expensive. Can we swap out a different prescription? And then they check on service and make sure everything was okay. Patients love that, improve safety and that sort of thing. Became completely unaffordable to hire a nurse to do that. And really only about 5% of the time they would find an issue that was important enough to do something about. So Auscura came from trying to reach those patients electronically. So we've been able to do that. We have even higher rates than nurses calling people back because everybody's got their phone within 3 feet and they're all addicted. And, you don't know where they're going to be. They may not be at home when the phone rings. So they will, with our system, get a text message, link in. We ask just a very few questions, mostly about well-being. When there's an alert, because they say they're worse, that will go to the case manager or a nurse in the emergency department. So those are the ones that, when they had to call 100% of patients and only 5% were important, they're getting those just to focus on. So that's an example of where we brought back checking patients the next day in a way that was affordable. I mean, it's really inexpensive when you set up automation and patients essentially are doing it themselves.
Yeah, that's such a great example, again, of that sort of marriage between a human process and a technological process. And what you're describing in terms of the patient care plan, ensuring that you're sort of plugging people into the network of care around, primary care or specialists or whatever it might be. It sounds like that is, I mean, really kind of going back to the shift to value-based care. We know that obviously admissions traditionally have been focused on fee-for-service models, but really what you're describing is sort of related, it sounds like, to that shift to value-based care. Can you talk a little bit about that?
It's pretty much what patients want, right? We don't want hospitals to focus on, I want more patients because I can make more money, I can order more tests, I can admit more people. So if you're volume-based, so you're fee-for-service, that is not really the motivation I think a patient wants, and it's certainly not what the government wants because they're paying for a lot of this. We have to switch to value. And so what is value? I use this acronym QUEST. It's the 5 facets of value. So quality, utilization, efficiency, satisfaction, and teamwork. So, some people would argue, well, what does patient satisfaction have to do with quality? This is interesting, and this has been published, that if you think about satisfaction, it is perceived quality.
Right.
So it's the patient's perception of quality. And the studies show that they're actually right most of the time. I mean, in anything in your life, when you interact with some service industry, when you got good quality. People spend time with you, they listen, they educate. Essentially, the patients can tell. They're using ChatGPT or Google. They know what you're supposed to be doing. Or at least if they kind of are a little too worried or think of a zebra when it's really not, meaning in a very unusual problem, you can educate them. You spend time, and they know that. They appreciate that. So quality is really important. And all the other things I mentioned, satisfaction is important because it is quality. And then efficiency and utilization is money. And then teamwork is what keeps people there, less burnout.
Right.
So just as an example, when we're grabbing information from patients the day after they were discharged, we will ask them about their service experience. And 90% of people want to say really great things about the nurses. And that the same nurse that was at the front of the ER staring at a busy waiting room, getting, just looking at the body language, people are not happy.
Right.
And they don't understand that most people actually appreciate what they're going through. They get it. And when the nurses get this feedback, so we will shower them with compliments, they kind of remember why they went into nursing in the first place. Right. So that's part of the value, I think, of what we provide.
Yeah, I think that's such an interesting connection. And certainly, I think you can put yourself in any sort of consumer situation where if you are satisfied with experience 1, you're far more likely to make it to kind of experience 2. And if I think about what you're building in terms of the ability to rope in a broader care plan, ensure that patients are getting to the right pieces and parts of the healthcare ecosystem after the ED visit. I mean, things like that in terms of the level of engagement that you get in those next steps, there has to be a connection to satisfaction with what they experienced in the ED as well. So I think that's just such a valuable connection. The other thread that I want to pick up on, you talk about teamwork, and you talk about the need to get people bought in and keep them engaged and so on and so forth. But I also know that change management in healthcare is really hard. So as you think about strategies that you've seen work when it comes to getting physicians, administrators, and so on aligned to try to solve some of these problems, what have you seen that works? What have you seen in terms of challenges, and how do you kind of overcome them?
Yeah, that's a tough one. So I think that the alignment needs to be around patient advocacy, around true value, like we talked about it. Like I said, borders are a symptom. Let's just think about borders. How do you fix that? How do you get people aligned? How do you change their practice? So one is, I think, just measurement. So some people don't appreciate how bad it is. So what defines a border? Well, people are admitted all the time. It takes a little while once you decide they're going to be admitted, to call report, to make sure the bed's ready and move them to it. They become a border. Most people would say if it takes longer than 4 hours, which is already, too long.
Wow.
But let's measure it somewhere. Let's draw the line. 4 hours above that, you're a boarder. Well, how do we fix that? We need to be held accountable. So far, there are no laws that require it. There's been talk of that. In other countries, there are laws. It's a huge deal. The Joint Commission suggests that you ought to not have boarders, but they don't have any teeth. The organization that I really want to give credit to, which is moving rapidly in this direction, is the Leapfrog Group. If you've heard of them, they're a nonprofit. They're a nonprofit watchdog. They are going to assign a letter grade to how you do in all the different things that they measure. Now they have boarders. So these letter grades are posted publicly. That's where the CEO gets, more motivated. They want to satisfy their community. The community says, oh, you're getting an F regarding boarding in the ER. Everybody knows that's bad. So now we're looking for solutions. Can we open up other areas of the hospital, add beds, add staffing, whatever it takes? So those are the kind of things I think that will create alignment on reducing boarding, again, a symptom of the entire system being a problem. And we talked about satisfaction, trying to focus on change management there. So getting physicians to understand that they're not a great physician only because they make the right diagnosis and come up with the right treatment plan.
Right.
I mean, that's really important. I get that. But they also have to connect to the patient. The patient, they have to be perceived as competent, they have to be compassionate, and they have to communicate well. So I think of those as like the 3 C's of trust. If you, in emergency medicine, I've got literally a few minutes for a patient to trust me. It's not easy. But if you listen, intently, and they understand that you're concerned about them, you take whatever the problem is very seriously, patient trust will lead to compliance. And therefore, you've taken your diagnosis, your treatment plan, and you've activated it. It now works, and you're getting better outcomes. So the great doctors need to understand that, and then we can work on them doing whatever they need to do to change to be perceived as a much better doctor.
I think that's fantastic. And we'll have to have Leah Binder of Leapfrog Group back on the show. We'll ask her specifically about boarding and spend some time on that.
Yeah.
But Dr. Scaletta, this has been a really wonderful conversation. I know we're just about out of time here. So I just love to open the floor and just, ask if there's anything else that you're working on or excited about that you'd like to share with the community here.
Yeah, there's something we are actively working on. It's a little bit early, but we've laid out the plans for it. And we're starting to move in the direction of building it. And this is the ultimate thing that improves efficiency. So patients spend time waiting in the ER. What can we do with that time? How can we make that time more useful instead of them just, sitting there staring at a TV or wondering why it's taken so long? There's an opportunity there where you could create a mechanism for them to give the information about why they're there, verify their meds, their history, and turn that into a cogent note for the staff. So like triage, patient walks up, they want to be seen, they're logged into the system. Sometimes there's a cursory set of vital signs, and really the story is just your chief complaint.
Right.
And there's going to be a little gap of time now before the triage nurse sits down with them, gathers more information, has to do these screenings for tuberculosis and travel history and depression, different social determinants of health. Do they have food insecurity? Those are all required things. They're all important things, but why not just let the patient complete it themselves? Why have a nurse have to articulate every single one of these things when the patient's there for an ankle sprain or fracture?
It's very interesting.
So those are the kind of things we can automate triage. We can get that information and turn it into a triage score, do a better job at all the patients in the middle. So 50% of the patients are classified as urgent. The severity score is a 3, ESI 3. Mm-hmm. That's 50% of all the patients coming in. How do we separate them? You can't just take them in time order. There's some that are a lot sicker than others. So our system that we're building will determine the triage score a little more precise. We can determine what orders can be done early on before the patient gets into the clinical area. We can do hourly check-ins. that's the project we're working on now that we're the most excited about.
Yeah, that's really interesting. And I have to ask you, please tell the community where to go to find more information about Auscura if they're interested.
Just go to Auscura.com. AUSCURA comes from the words aus, to listen, like auscultate, and cura, to help. So we're trying to listen to patients and do what, the kind of things that'll improve their outcomes.
That's awesome. And we'll link to that obviously in the show notes as well. But Dr. Scaletta, this has been just a great conversation. Thank you so much for joining us. And it was such a pleasure to get to talk to you again.
Thanks again, Chris. I appreciate your time.
Absolutely. And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn a little bit more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's our show for today. And until next time, I'm Chris Civitaris, wishing you health and good cheer. Take care.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.
Health literacy benefits patient and provider alike, but how can patients take control of their own care? Introducing iMed Health from Taylor Healthcare, digital tools that support patient education and health literacy. Go to imedhealth.com to learn more. Find the link in the show notes.